It's 3 o'clock on the dot. I think we'll wait a few more minutes to see if we can have additional people joining us. Numbers are steadily climbing. Can you all hear me?
Yes, hear you.
Great. Another minute or so. So let's make a start. My name is Colin Suwuji. I'm faculty in population science at the Africa Health Research Institute and professor of global health and HIV medicine at the University of Sussex. I'm the academic lead for the ARI Health and Demographic Surveillance System, which is one of the seven SAPRIN nodes. Okay. Today is actually the first time this meeting is adopting a webinar format. I hope everyone didn't have that much trouble registering and getting connected to the meeting. So today, I have the pleasure of introducing Ms. Gloria Sukali. Hello. The pleasure of introducing Gloria Sukali, who has a Master of Medical Science degree from the University of KwaZulu-Natal. Gloria is a PhD student at University College London. Her PhD work is investigating the relationship between the pharmacokinetics of nucleotide analogs and hepatitis B virus activity and viral control in individuals and populations. Today, Gloria will be talking to us about one of the objectives of her PhD. She's generated some preliminary results, which she would like to share with us today. And the title of the talk is PrEP Programs, PrEP for Pre-Exposure Prophylaxis Programs as a Framework for Tackling Hepatitis B virus infection in Adolescents and Young Adults in KwaZulu-Natal, South Africa. And just before I hand over to Gloria, I just wanted to say at the end of the talk, you can unmute yourself and ask your questions. Alternatively, you can use the chat function you can use the chat function for your questions, and I'll read out the questions. All right, Gloria, over to you.
Thank you, Collins, for such a wonderful introduction. I am going to share my slide. Please let me know if you see anything on your side.
Yeah, I can see that.
Okay, I don't think I'll be able to see any of you guys. I'll just switch off my camera for now and present it. I'll put it back on. So as Collins has mentioned, I'm going to be giving you a talk on PrEP programs as a framework for tackling HPV infection in adolescents and young adults in KwaZulu-Natal, South Africa. See. Okay, so you might be wondering why we decided to work on why I have decided to present work that has to do with the hepatitis B virus. And I'd just like to highlight that hepatitis B virus is a neglected disease. And then why should we be studying hepatitis B virus? So I'm going to give you the global stats. According to statistics in 2022, globally, there are 254 million people that are currently living with hepatitis B virus, and 65 million of those people live in the African continent. I'd also just like to note that deaths due to hepatitis B virus have increased from 800,000 to approximately 1 million. In the South African setting, 1.9 million people are currently living with chronic hepatitis B virus infection. The vaccine coverage in South Africa is estimated to be at 79%, even though I'd like to note that vaccine introduction or vaccine immunization in South Africa for hepatitis B virus was introduced in 1995. The KZN HPV vaccine coverage is estimated to be at 75%, and the prevalence of hepatitis B virus in the KwaZulu-Natal area is at 10%. Here, I would just want to highlight my research institute, ARI, highlighting that we are currently doing HPV research at the Africa Health Research Institute. We also have HPV research being conducted at the Francis Crick Institute in London and at UCL. And also, I would like to highlight that I'm also a member of the HPV Elimination Lab, which is led by Prof. Matthews at the Crick Institute. So, normally, the first line of treatment for hepatitis B virus is tenofovir, which is the preferred line regimen. Also, tenofovir and entecavir are also used as preferred regimen, but due to challenges in accessing tenofovir monotherapy in the African settings, the WHO has adjusted the guidelines which allow for dual therapy for treatment for hepatitis B virus. In this case, TDF, XTC, and XTC covering lumevidine and emtricitabine as well. We hypothesize that decentralized HPV screening, treatment, and prevention will improve access to treatment. We'd also like to note that tenofovir and XTC are also used as PrEP for adolescent and young adults at risk of HIV acquisition. We therefore hypothesize that HPV programs in the African settings can use HIV infrastructure, in particular building on PrEP programs for access to HPV screening and TDF-based treatment. The data presented in this project was obtained from PrEP studies that have been conducted at the Africa Health Research Institute, known as Tetanami Ngitetenawe, and the long-acting HIV pre-exposure prophylaxis known as LAPIS. These studies set to assess or provide assessment needs to adolescent and young adults at risk of HIV acquisition, in collaboration with Evolve HPV, which is the hepatitis B virus project being conducted at the Africa Health Research Institute, which sets out to describe HPV epidemiology in the KZN population, characterize clinical and laboratory features of HPV infection, and engage with local communities and healthcare providers to implement a sustainable care pathway to diagnosis due to challenges in accessing care for HPV diagnosed patients. So in this case, Evolve HPV as a whole explored PrEP uptake and retention care cascade among adolescent and young adults, in this case 15 and 30 years old, living with HPV through the decentralized studies. Panel A highlights the collaboration between the PrEP studies and Evolve HPV studies, and Panel B highlights the pathway offered to adolescent and adult showing up for HPV screening, assessment, and how they are offered PrEP. All the participants in this study underwent a clinical assessment, and as part of this, they were offered a routine HPV point of care test, and if they had tested surface antigen positive at point of care test, this was then followed by a laboratory confirmation test. They were assessed for PrEP following the the PrEP eligibility and risk assessment based on the South African National PrEP and ART guideline. And if they were eligible for PrEP, they were put onto treatment, providing them with the combination treatment for HIV and HPV. And then they were followed through care cascade through Evolve HPV. Yeah, I just want to highlight that this is the care cascade summary for the HPV screening, linkage to care, as well as receipt of PrEP and the continuation of PrEP. I want to highlight the colors. The purple boxes just show the individuals who were surface antigen positive, but then did not take up treatment, or they fell off at some point. So at baseline, we started with over 3,000 participants who were screened for HPV, and of this, we had 21 individuals who tested positive for hepatitis B virus. One of our participants was already on ART for HIV treatment, so we did not include them for PrEP eligibility. This left us with 20 individuals who were assessed for PrEP, and of this, 24 were considered not eligible, 16 were considered eligible for PrEP, but one decided not to take PrEP. So in total, we had 15 individuals who started their PrEP treatment. And over time, they all had to come back for at least 1 or 2 PrEP refill, depending on when they were initially diagnosed to be surface antigen positive. We had 14 individuals who were due for at least 1 PrEP refill, but then 6 did not return. So we ended up having 8 who came back for at least 1 refill. And of the 8, 2 did not attend their second PrEP refill, and then that left us with 8 individuals who returned for their second PrEP refill. I just want to also highlight here that at each step of the care cascade, we are losing patients. So it's also just like important to highlight this as a gap that we still need more interventions to address barriers to sustainable delivery of long-term care for people living with HPV virus. So the learning point from this study has been that tenofovir XCC combination therapy for HIV and HPV supports, first of all, this decentralization and task sharing, as well as improving access to treatment. We also want to note that capitalizing on frameworks for HIV and sexual reproductive health services will improve pathways for HPV diagnosis and access to treatment. It is important to integrate sexual reproductive health services, HIV services, as well as hepatitis B services to enhance education, screening, family planning, perinatal care, as well as prevention of mother-to-child transmission. Here, I also want to note that we had very small numbers. So out of the 3,000 that were initially assessed at baseline, we only had 21 individuals who tested positive for hepatitis B virus. So it's kind of like difficult to make a comment on the rate of acceptance or long-term continuity of PrEP. We are hoping to expand this project, so I think I'll be in a position to comment further on the numbers presented or on the continuity of PrEP if eventually we have an expanded number of people that we screen. We do have vaccine coverage data which was incomplete. One of the challenges is that despite the fact that hepatitis B immunization was introduced in 1995, the age group that we're looking at or who were assessed for hepatitis B virus were all born after 95. So presumably they should have all been vaccinated for hepatitis B virus, but we had incomplete data. So we really can't comment at the moment on who was eligible for for vaccine, who was offered vaccine, or who completed the vaccine schedule, because they are required to have 3 vaccines from 6 weeks after birth, and 10 weeks and 14 weeks as well. Based on the gaps in the vaccine coverage, we do note that we do have some adolescents and young adults who tested positive in this setting. So it's kind of like worrying. And it's also just like highlighting that we need to put more effort in making sure that the infant vaccine coverage is reinforced to make sure that the age groups that are born after 95 are actually vaccinated accordingly as they should. also want to highlight that with the current PEPFAR funding cut in 2025, a lot of HIV studies are facing challenges, and as such, there's going to be an increased risk of HIV transmission, and through this, there's going to be some limiting in accessing PrEP and HPV treatment, which is what we're actually trying to leverage on in the study. I'd like to acknowledge my supervisors, Prof. Matthews and Prof. Iwuji, as well as our collaborators at the Africa Health Research Institute, and the participants of the Tetanami and the LAPI studies. Thank you very much.
So thank you, Gloria, for that presentation. That was a very short one. I just wanted to highlight the relevance of the study to SAPRIN. The Tetanami study that Gloria mentioned was nested within the ARI HDSS, and the HDSS was used as a sampling frame for those studies. And that's why we thought it was appropriate to present that in this meeting. If there are questions, this will be the time to now ask them. Or you can use the chat function to ask your questions and I'll read them out. Okay, so Andre.
Thanks, Collins and Gloria. That was fascinating. I wonder if you could maybe just chat a little bit more about the sampling and how you did it, and the methodology employed, and how the HDSS was used for that. Why did it come in helpful? Thanks.
Okay, so I think I'm going to just to highlight on what Collins has spoken on, the LAPIS studies that were conducted, LAPIS and the Tetanami project were all nested within the HDSS surveillance area. So as part of those studies being in that area, and I'm also doing an HPV project, which is actually using Vuguzazi data, which was also collected as part of the HDSS sample area as well. We found it fit to actually.
We can't hear you anymore, Gloria. You've cut out.
So the sample that was presented at baseline, the 3,432 individuals, they were participants of the Tetanami and the LAPIS study. Basically, the studies are trying to give HIV assessment needs to adolescents and young adults who are at risk of HIV acquisition. And as such, they then had to undergo a routine hepatitis B virus testing, which is where we come in, because we are doing a HPV focused project and we take them from there.
Yeah.
Hi, Andre. Yeah.
Yeah. So I'll just give a brief overview of the Tetanami led by Professor Shamanesh. I wasn't involved in this study, but my understanding of the Tetanami study was that they were looking at both HIV positive and HIV negative adolescents recruited in a cluster randomized trial with a number of interventions evaluated to reduce transmissible HIV. That means if those who were negative, they were given PrEP to remain negative, and those who were HIV or living with HIV were started on antiretroviral therapy, if not already on antiretroviral therapy. And the outcome was the prevalence of people without transmissible HIV, as in if they were positive, their viral load needed to be undetectable, and if they were negative, they needed to be on PrEP. And as part of the evaluation of these individuals, a rapid hepatitis B test was done on everyone, either starting HIV therapy or being prescribed PrEP. So those, I think that was where Gloria then took the sample from. So for all individuals testing negative who were on PrEP and had tests for hepatitis B, then were sort of formed the baseline sample for this nested study. And the LAPIS mainly was only comprised HIV negative individuals.
Okay, thanks so much. I have another question. I was just wondering, Gloria, if you knew anything
Yeah.
about the clades of the virus, or if you didn't look at it.
For HPV, no,
Yeah.
I'm yet to look at clades of viruses. No, I haven't gotten that far yet.
But is it part of the plan?
No.
It is objective 3 of Gloria's PhD. She will be doing some sequencing in people with detectable hepatitis B viremia. And as part of that, she will become aware of the genotypes of the virus, of the hepatitis B virus.
Okay. I think it would just be interesting to see if it's the same virus family that's circulating, or
No,
you
I
know,
think it's going to be different because in the sub-Saharan area, there's different types of hepatitis B virus strains that are going around. So I think we'll definitely see a few different strains. Also, just keeping in mind that if there's been a bit of a migration here and there, we're going to maybe get a mixture of strains that we'll see.
Yeah, but I meant like within that HDSS, what's circulating there, if it's similar,
Yeah.
or if people are bringing in virus, and if it's correlated, especially with the migration of the individuals, if there's any correlation between the clades and what's happening at the phenotypical level with the migration. Thanks.
Yeah, I think just like as Colin says, maybe once I've done my objective 3, I'll be in a better position to expand more on this. Yeah.
Johnny?
Thank you, Gloria. Yes, hepatitis is neglected, and this is important work. Just 2 questions. The one is, how do you understand the low positive rate of 0.6% if KZN is on 10%? And then the second question, is it fine if I ask both, Collins?
Yes, go ahead. As long as Glory will remember the second question.
Yeah, I was about to just tell you to repeat the first one
and
then let me answer the second one. Yeah.
The second one is just, we know that people default or non-adhere a lot on PrEP, but if you are doing this within the HDDS, how do you understand the fairly high number of people who actually didn't come back for the treatment? It's just those two questions. Thanks.
Yeah, I actually was going to ask you to first repeat your first questions.
Okay, the first one is, you found 0.6% people
yes,
positive, but the KZN background prevalence is reported
really
as
high.
10,
Yeah, it's 10%.
yeah, as 10%. Now I know that these things happen, but how do you understand it? Thanks.
So the low prevalence in this group that we studied could be due to the age group that we focused on, which was 15 to 30. And as I had mentioned before early in the talk, is that this age group was born after the HPV vaccine immunization was introduced in 95. That would be one of the reasons why we did observe such a low prevalence in this group that was analyzed. Can you please repeat your second question?
Yeah, you haven't finished answering the first question though. And so how does that correlate with the 10% prevalence you also quoted for hepatitis B in KZN? I'm sure you have the answers there.
I think in as much as the prevalence is 10% in the KZN area, I don't think it's actually a true representation of the area that we're looking at.
No, actually, I think the reason for the prevalence of 10% was that the sample cut across different, both pre-introduction of
And
the
up and
vaccine
post, yeah.
in 1995 and post-vaccine. So when we did a stratified analysis, it was a lot higher pre-introduction of vaccine of hepatitis B immunization. So bringing the data together, the prevalence still sits around 10%. But if you focused only on people born after the introduction of the vaccine of hepatitis B vaccine, then the prevalence is a lot lower.
Yes, I think that's very that's understandable. I think that just highlights the issue of the importance of local context, and that work is done in different SAPRIN sites so that you could accommodate or actually see the major differences that local context is very important. But Gloria, the second question is just about the patients that did not come back for the continuation. We know that this is the situation with PrEP, but I may make it such that you could have higher follow-up, and that do you have actually information about those people who didn't come? Thank you.
So we do have information of the people who did not come. So each time they have to come back for a refill, they're actually normally contacted, and then to be reminded that they are due for a follow-up. It's kind of like challenging to fully comment on the reason as to why they did not come back. I do know that there are a few reasons that would lead one to choose not to decide to come back for treatment, which we've nicely outlined in the manuscript. And some of them just include stigma, pill burden, and all that stuff. But in this case, we haven't really followed them up and actually find out from them the reason as to why they chose not to come back, if they are notified or if they are called or reminded to come. Maybe that would be like another study separately to just try and find out from them the reason why they chose to fall off.
Yes, thank you. I think I just want to comment that it to me also indicates that when we design health interventions, actually coordination of care and patient input is probably important enough to include it in the science or the research design or something around that. Thank you.
Yeah, no, I fully agree with that. Maybe just like trying to consider what would be the best way in which they'd like to receive or to be notified on coming in for their follow-ups. And yeah, I think it's very important to consider as well. Yeah, I fully agree with that. Just having their input as well, so that they are not fully obliged, or if there's no approach or method that's just like forced on them that you have to come this way. Maybe we have to figure out what works out for them, I think. But that might just also just like be difficult, because if you give everybody the liberty to tell you how they want to come and get the treatment, I don't know how many pathways we're eventually gonna have to make sure that these people actually return for treatment. So I think, in as much as we'd like to consider it, it's also just like it's gonna require a little bit more of thinking, because everybody would just like go wild if you let them decide on how they'd like to maybe come back and receive their treatment after they've started. Yeah.
There's a question on the chat, Gloria. It says, have you experienced any resistance to the regime used for hepatitis B virus treatment, and also any viral breakthrough with the same regimen or treatment?
So with the sample set, we haven't tested them to try and see if there's been any. You said the drug resistance. Let me see. Let me just double check.
Yeah, any resistance. Yeah.
No. We haven't tested them yet. This set only. But from one of my other PhD project objectives that I'm working on, we have quantified drug levels, and we're seeing something that might be leading to some regimen resistance. So I'll maybe be able to give more information on that once I've fully developed that objective, but it's still ongoing. But in this set, no. So then that answers the question on viral breakthrough as well. No, in this set, no, I haven't seen.
So it's gone quiet. I have to assume there are no more questions or comments. Thank you for your attention, and Gloria, thank you for the presentation. Yeah, I'm back to you, Andre. What's next?
Thanks, Collins. Thanks, Gloria. That was interesting. We hope that we're going to see some follow-up maybe in a couple of months' time to see how far you've progressed. And yeah, hopefully you'll also get an opportunity to present this at the SAPRIN conference one year. From our part, just to remind people that we have moved to the seminar based format, and if you can just continue to spread the word, and as the adverts come out, to register for it. And unfortunately, we don't have the option for putting it into your diaries on a recurring basis with this function. And yeah, Rupa, I think I saw your hand. I don't know if you still wanted to say something.
I know, I just see Nelly Siwe had added a question here.
Oh, okay.
All right.
Yeah, so
okay, you've seen it, Gloria.
Yeah. I've seen it. Sorry, there was a bit of a disconnection. So Nelisiwe is asking, for individuals who tested HIV negative when treated for HPV, are the chances of developing drug resistance in the future when tested, if they test HIV?
Gloria,
Oh my God, sorry. Yes, yeah. Can you hear me?
We can hear you now, but you were frozen for a bit. Yeah.
Okay. I hope everybody did get a bit of the question from Nelisiwe. Well, sometimes when you start one treatment treating one disease, and then if it has to treat another one, and you've been on it for a very long time, there might be chances of maybe resistance, especially if you've been on a certain therapy for an extended period of time. I'm not saying it will happen, but the possibilities are there. Collins, since you're the HIV expert.
Yeah, you want Madra's answer to begin with. So I'm not aware of, for example, cross-resistance between hepatitis B virus and HIV, but there, for example, let's use lamivudine as a drug used to treat hepatitis B, which also has activity against HIV. You can develop 100% lamivudine resistance, and it will be inactive for hepatitis B just within 4 years of use. But then the lamivudine will still be active if someone contracted drug-sensitive HIV. So it wouldn't be because they've been exposed to lamivudine for the treatment of their hepatitis B if they didn't have HIV to begin with. So there'll be no pressure, there'll be no virus for the drug to exert a pressure on, which leads to resistance. Of course, unless that person inherited, got infected with a resistant HIV to begin with, not driven by the drug being used to treat hepatitis B. So it depends on whether the person was affected with wild-type HIV virus or resistant HIV to begin with. But there's no cross. In terms of the resistance patterns, there's no cross resistance between those two viruses, as far as I'm aware.
Yeah, I think, thank you, Collins, for highlighting that. I think I had missed most of what Andre had said because I don't know what's going on with the Wi-Fi at the office. it's breaking off.
No, I was just thanking you for your presentation and saying that I hope that we have the opportunity to see the follow-up work in the next, I don't know, months to a year or so, and that you would take the opportunity to present it at a SAPRIN conference sometime.
Thank you.
But yeah, I don't have anything else to add. Collins, your side?
No, I'm good. Thank you.
Okay. Any closing remarks, Gloria?
No, well, just thank you for having me. I think this is the first time I get to present for SAPRIN, even though Collins has large affiliations at SAPRIN, and as my co-supervisor, I don't understand why he's never forced me to actually give a presentation at SAPRIN yet. I think it's long overdue. It's been over a year.
Okay,
It's
you
just
can,
a bit
you
of
can
time.
submit. Okay, we'll talk about that then. Yeah.
Yeah.
Moswedi was at the last SAPRIN
Yeah,
conference. as
yeah.
well.
That I think with me, we just like let her focus on other stuff for now.
Yeah.
Yeah, we have a lot going on.
Okay, thanks everyone, and thanks for the rest of the participants, and we hope that you have a great day further. Thanks, bye.
Thank you very much. Thank you.
Bye-bye.
Oh my goodness.